I'm a big proponent of partial knee replacements or uni-compartment knee replacements. So this is sort of my talk on how to get a good result and how uni matters in the Indian scenario as such. So no disclosures, I drive a car with something like that in front rather than a Rolls-Royce or a Mercedes logo there. So what we are looking at, this is an opening statement which you may not like. I do a lot of joint preservation surgeries. So I'm a big proponent of HTOs and unis. I don't do TKRs unless my hands are really tied. For those who are still doing arthroscopies and osteotomies, there's a very famous statement that total knee replacement is internal amputation of the knee joint. So of course we know below knee amputees fare much better than above knee amputee. So same scenario applies here. A partial knee will work really better as compared to total knee in properly selected patients. So someone like this MCOA managed with a partial knee replacement will have a nice next 20 years of normal knee function as such. Okay, so why uni? Lot of papers say that uni is superior to total knee replacement. A lot of surgeons are hesitant to admit that, but technically speaking, in properly selected patients, either too young or too old, unis do really better. The rate of revision of uni has been slightly higher throughout in the world. That's because it's very easy to revise a uni to a total knee replacement. And there's a very famous paper from Oxford group, Goodfellow group, which talked about how people are less hesitant to just convert a uni to total for even minor knee pain as such. Okay, what about Indians? We are of a smaller stature as compared to the Caucasians. We have slightly higher BMI. We generally have a bit of osteoporosis after the age of 45, 50. Generally, we have smaller size bones, especially in females, where you do size 1 or size 2 femur, and males normally go for size 3, 4 implants. All of us like to sit cross-legged, and all of the patients that you see, they want to start yoga, running, or treadmill post-surgery. So they may not be doing anything before, but they would always want to do something after the surgery. So we are special people, as we all know, and so we all expect to sit in a Vajrasana or a deep knee flexion position post-surgery. So things have changed a lot from, let's say, 2001 to 2024, where the size of the TV has gone down and the size of the tummy has gone up significantly. About my experience, I was doing completely Oxford's before 2012 and shifted to fixed bearing implants since 2012. And last 13 odd years, I've been just doing partial knee replacement using a fixed bearing system, and I'm entirely happy with this. So of course you need to select your battles, so always need to select your patients. So any patient who specifically points to the medial compartment as the site of pain is sort of ideal for a partial knee replacement when confirmed that he has a grade 4 OA on the medial side. PFJ pain may or may not be present. Generally grade 4 arthritis will present with rest pain and night pain, and these generally need regular analgesia. So these are sort of ideal patients that you see. We always look at alignment, so always need to make sure that there is no significant malalignment that is there. You need to look at thrust. A lot of times there is combined ligament injuries at the same time, and that might change your management. Fixed flexion deformity generally is very tricky to sort out unless it's coming due to osteophytes on the medial side or on the back of the medial femoral condyle. Again, stability of knee is essential. So you have to make sure that the ACL and PCL are still holding. Otherwise, you can add that at the time of surgery as well. Always get standing X-rays. Don't get supine X-rays. This is a very famous lab in India which had this campaign of X-ray which was held upside down and became a laughing stock for quite some time. Okay, so the lateral osteophyte is completely acceptable. Patellar osteophytes are acceptable. So such an osteophyte on the lateral compartment is completely normal. It does not denote any affection of the lateral compartment as such, and is very commonly found in patients with a completely normal lateral cartilage. We I normally recommend getting a scanogram as well. This was based originally on the Scott and Cousin criteria, where they said the combined flexion deformity and varus deformity should not be more than 15. That was generally applicable for mobile bearing unis, but not for fixed bearing unis nowadays. But the scanogram also helps you in looking at any pathology in the hip which can be contributing to this, any leg length discrepancy or any femoral pathology at the same time. So just looking at a knee X-ray may not be enough. Quite a few times you have something like this, where if you miss that, you might not get a perfect result and you might end up doing a wrong surgery for this patient. I think all of the patients that you are doing a uni, I would do a MRI. In my practice, it's a must to get a MRI done. We need to confirm that there is grade 4 medial compartment damage, but the lateral compartment has to be fairly well preserved. I do accept a moderate level of lateral compartment arthritis also, because I'm going to put the patient in varus position again. So the loading will happen exclusively in the medial compartment, but a lateral meniscus tear or a ACL, PCL integrity and a lateral femoral condyle edema generally is a deterrent for going for a uni as such. PFJ affection may or may not be that relevant in today's day and age. As we all know, patellofemoral joint likes varus but does not like valgus. So if you're keeping the knee in varus, they're generally pretty happy as such. Generally speaking, arthroscopy should not be done before a uni. Arthroscopy has been considered as a, let's say, semi-sterile procedure, so it should not be done just before a uni compartment knee replacement. If you're getting a MRI arthroscopy, I'm sorry about this, it's not me doing it, but unfortunately there's some flickering. But if in doubt, you can always get an arthroscopy for, let's say, a week before surgery if you want to confirm that. When there are multiple contributors of pain, so the patient has hip pain, back pain, as well as knee pain, it sometimes is slightly tricky. You can think of getting a bone scan done in such patients, and that normally clinches the diagnosis that there is exclusively medial compartment arthritis which is contributing to the patient pain. A quick example, typical MFC weight bearing area grade 4 changes. There is bony edema pattern, there is a root tear at the same time. The medial patellofemoral joint is slightly affected, the lateral is decent. There is a lateral osteophyte, as I said, it's acceptable. The lateral meniscus is intact. I'm certain to give someone a Caesar with this. Yeah, so a standard partial knee replacement such as this works best in patients such as this. So sort of an ideal patient for this. What about this? So there is a bit of affection of the lateral compartment. I'm not touching the wire also. It's okay, so the lateral patellofemoral joint is slightly affected, but that should not deter one from doing uni, because as I said, you're doing uni in a keeping the leg in a varus position. The patellofemoral joint is generally happy. We have slightly pushed our limits now with a fixed bearing implant. So this is a 50-year-old, slightly overweight person with significant pain in both of her knees. Look at the left knee. There is very significant varus deformity where the Mikulicz point is now falling beyond the medial compartment outside the knee joint, and traditionally this has been considered as a contraindication for a partial knee replacement. So you can correct a lot of deformity based on your bone cut. So if you look at this bone cut, almost 0 mm bone cut on the extreme medial edge, but there's a lot of deformity correction can be done just by doing, should I play that? Let's try again. Take that off. This is working before at least. Should it work now? Okay, perfect. So again, the same thing. So we will just go back to, yeah, so significant varus normally deters most people from not doing a uni, but you can achieve a lot of deformity correction based on the bone cuts that you do. So if you take 0 mm cut on the extreme medial edge, you can correct the deformity significantly, and this person will get a really good looking knee which is stable and mobile without any issues, with good deformity correction. This was done just, I think, a couple of weeks back. Very pretty happy mobile patient as such. Again, same thing, bad PFJ, you can still do a partial knee replacement without any issues. A lot of factors have been discussed about whether you should do a uni or not. I'll quickly go through them. Too young or too old is completely a question of your own belief. So 49-year-old female, bilateral uni done really well. 84-year-old lady, 2 years post-op from a partial knee replacement bilateral done really well. Same lady showing her range of motion. This is a 53-year-old gentleman who's done remarkably well. This is 2 years following his partial knee replacement. Socioeconomic status is always stated as a criterion for deciding whether someone should get an osteotomy or a uni. That's a housewife, around 60 years old, who had a partial knee replacement. That's mother of a physio who got a partial knee replacement. The one on the left side is a retired CEO of a multi-million-dollar company. One on the right side is a gentleman who works as a driver. That's the same gentleman. 7 years down the line, his hair has gone white, but the knee seems to be holding really well still. BMI is always cited as an issue. Apart from finding the knee joint when you're doing the surgery, everything seems really easy. You can find the knee joint, then you can do a partial knee replacement easily. They are able to go on a cycle within 2 weeks. So you can see the lady there, you can still see the dressing there, and they're able to go back to normal activities. PFJ has been cited as a very important factor in reducing the pain benefit that the patients get. I don't believe so. Pre-existing patellofemoral disease, I don't think affects the survivorship in a fixed bearing uni. And I have done uni in a lot of patients with PFJs looking like that, and they generally manage well. I do take out the osteophytes when I'm doing the surgery. Ultimately, it's all a game of expectation. The same gentleman I showed before wanted to run. I said no, he still ran without any issues. This is 2 years post-op X-ray, looks absolutely fine. This lady, I told her not to sit in Padmasana. She refused. She started sitting in Padmasana pretty comfortably. Is a yoga enthusiast. So extreme movements are also possible without any problem. There are certain times when you can do uni as a sort of salvage situation, a failed HTO. If the HTO is not done well, then actually it's very easy to change to a uni. So if MCL release is not massive, then you can certainly do a uni without worrying too much about it. What about ACL? You can combine ACL and a uni in same surgery. That's 2 years post-op from a partial knee replacement with a ACL reconstruction. Absolutely fine. He was very stiff to begin with, but has gone back to complete normal life now. Another patient, all inside ACL along with a partial knee replacement, and done really well. This is only about 3 months from the surgery. She's able to walk well. Her range of motion has come back normal, and the knee is super stable. It still looks swollen because it's only 3 months post-op. And come on. I'm very sorry, it's just not working today. So the biomechanics of a partial knee replacement almost mimic a normal knee joint, and this is something which improves the patient's perception of the knee. There is a famous study which looked at the stair climbing ability of a patient post-surgery, and they found that they're able to do really well. X-rays are very important, but they are more psychological than anything else. I normally just look at the lateral view nowadays. Don't look at the AP view post-operatively, because a lot of times you'll see an AP view like that, and the patient will also be confused if the X-ray is not done properly. A lateral view normally shows if the joint is fitting properly or if there's any issue as such. In an ideal world, I'll always get an X-ray like that, where you get an end-on view of the femoral component and the tibial component, and you get everything which looks perfectly fine. Oxford group has come up with a lot of radiological criteria to confirm that the position is perfect. That's one of my own patients, I think, long back, and we used to do this for every patient. But with the fixed bearing, things have changed a bit. You don't need to worry too much about your radiological parameters now. All you need to make sure is that your posterior spike is in line with the posterior cortex. Your tibia is not overhanging posteriorly. Your anterior margin of the femoral condyle is well buried inside and is not prominent, otherwise it will irritate the patellofemoral joint. You haven't cut the medial tibial spine, and your keel is not touching the posterior cortex. If you follow all of these things, then generally speaking, it's a fairly straightforward surgery. I don't mind a millimeter or two medial prominence of the tibial component. That doesn't deter me at all. I went through a phase where I was doing bicompartmental knee replacements, where I was changing the medial compartment as well as the patellofemoral compartment. Gladly I've stopped doing that. I don't think that makes any changes. A big subset of patients who are happiest of all are lateral unis. So patients with lateral compartment OA are generally very happy when, I think it's me moving which is causing it. I should just stand still. Yeah, so these are a couple of patients showing the journey of a partial knee replacement. The guy on the left hand side obviously is showing off. He's about 3 days from surgery from bilateral partial knee, and he starts by saying, I started walking with a walker on the day of surgery, and the next day I was doing absolutely fine, and then I threw the walker away and I became completely normal. He's a dentist based in USA and doing really well. The lady on the right side had a TKR done by me about 1 year back and reluctantly agreed for second surgery, and when I said we'll do a partial knee, she was quite delighted. This is 2 weeks post-op. You can see her gait has improved drastically. She's walking well without any issues as such, and they're generally happy patients if you explain things to them and allow them to do whatever they want to do. I will not go through literature just now because of lack of time, but generally speaking, unis are performing better in terms of their function than compared to TKR at midterm and early follow-up. The revision rate also is not massively high. There's not much of difference between mobile bearing and fixed bearing unis as such, and I think satisfaction rate following a partial knee replacement is significantly higher as compared to total knee replacement. I won't go into that. Just one final example, 6 years from right side, 2 years from left side. She has a tendency of calcification at various spots in her body, but done really well. Unis are tougher than total knees and are less forgiving, but still make some of the happiest patient if you follow the specific steps that you do for a partial knee replacement. The truly forgotten knee score, I think, can be achieved really well with a partial knee replacement. So it's very gratifying when a person comes back to you after about 3 months from surgery and shows you that he or she is able to do all of these activities without any issues. He's had both of his partial knees done and is doing good amount of work just now. I think I won't bore you too much. That's all I wanted to say. So thank you very much, and let's not fool ourselves about our weight as such, but partial knee I think is going to stay. Thank you.